Hi guys, so here's the pediatric orthotics and splinting slides. Let's see here. So there's three different types of splints that we're going to be talking about for pediatrics, and that includes dynamic, semi-dynamic, and static. So in your adult class or theory class, you made only static splints, right? So the dynamic and semi-dynamic splints are new for you. So dynamic splints create mobilization, so being able to move the joint. It can also create traction. So they're kind of scary and have lots of moving parts. So these are not used with kids very much. I've never seen them used with a kid. However, it is an option. Especially you might see these dynamic splints that help to create mobilization or traction in adults more so. So this is an example of a dynamic splint for a child. It could, because it's moving at the joint, at the knee joint and the elbow joint, it could be set for a certain amount of tension. So maybe you have tension trying to get that into extension. So the elbow splint there could be set, set so that they can only flex it to a certain point, and then the rest is all extension. So in the dynamic splint category, there's ultraflex. So NMES, we learned in the CP lecture, means neuromuscular electrical stimulation, and it creates movement or stimulation in the muscle. So for this ultraflex dynamic splint, they have electrical stimulation on the tricep. So when he pushes the button in his right hand, the control there, he's going to be stimulating the tricep, which will help to create movement in the tricep through that dynamic splint. NMES can also help to decrease upper extremity spasticity. It's used to activate the muscle, and it can also help to decrease spasticity. So there's also semi-dynamic splints, and this is what I see mainly used with kids for their upper extremities. There's no moving parts, but it does allow for some movement. So neoprene is that material that is like wetsuits, and so if you've ever tried to get in a wetsuit, you know that it kind of like gives you some resistance, but you can still move around in it. So it optimizes the already existing movement or positioning. So if I was to put a little soft hand splint on, it's not going to hold me in a specific position, but it's going to prompt, like if I have a neoprene material here, it's going to prompt me to be able to open my hands better than if I didn't have anything there. But it's not hard like a static splint that's going to prevent all movement. Let's see. I think we're going to get into that farther. So tone and positioning splints, or TAP splints, these are semi-dynamic, so they're soft-ish, and it creates so they twist around. I'll show you a picture in the next slide. They twist around and help to create supination. So a lot of kids that have spasticity go to pronation and really high tone. So these tone and positioning splints, they are the tan part of this picture. So we have a semi-dynamic wrist splint on this child's left hand. And then there's tone and positioning splints, which is just the neoprene that's wrapped around his arm up to his elbow, and it's helping to bring his thumb out into supination so that he has a better chance at using that left hand to grab something. Some different brands of semi-dynamic splints that are very popular with kids in occupational therapy are Joe Cool and Benick splints. Those are just brands, but these are great pictures of how simple a semi-dynamic splint can be, but it helps. A lot of these are helping with some abduction and extension so that they are not in a real tight spastic position, because if you are, you can't use your hands very well. Moving on to static splints, which I know you know the most about, they are used for immobilization. If I say, how will we immobilize the joint? Static is the choice. It's supporting the joints and creates no movement and has no moving parts. Resting static hand splints. You made some of these, I'm sure. You should not need as much padding as is in this picture if you have smooth edges. Let's see here. So this is another example of a static splint. This is an airplane style splint that you can see in his axilla or his armpit. He's been burned. And when a child's been burned, or when a person's been burned in a joint, it has a high probability for contracture. So you need to splint against the direction that the joint normally goes in, and then go past that, either hyper extension. So if it was the elbow, you would never splint it in a flexed position. It would be full extension. Same thing with armpit. Same thing with neck. And the neck is a really high probability for flexion contracture. So you want to hyperextend whatever joint it is and splint it in that position if there's a burn. So these are anti-deformity splints for burns. Let's see here. So in nursing homes, you may see these comfy splints, or for kids like with a massive traumatic brain injury. As long as the soft part can be taken off to be laundered, then that's okay. Otherwise, they can be hard to wash and harbor a lot of bacteria. So make sure that there's a zipper or something that can come off and get washed. The comfy splints could be helpful if a child has really super strong spasticity or muscle tone that it's really causing a lot of breakdown and injury to the skin. Then obviously this would be an okay choice. Also, I know you made a whole bunch of splints, but a lot of these are now straight off the shelf, being like you buy the splint and then you just adjust it to the person's hand. So if you are a hand therapist working in an outpatient clinic, then you're probably going to make a whole bunch of splints. Otherwise, you're probably going to buy the splints and then adjust it to the child. That's probably the way it's going to go down. So static progressive splints. These are static, so they're hard, but you are progressively changing the degree of the splint over time. So maybe you have a splint on for a week or an orthotic on for a week. And then let's see here. If they have high muscle tone with wrist flexion, and we're trying to progressively get them into neutral, you might start with a static splint like this for 1 week. And then the next week you move it a little bit more into neutral. And the next week, a little bit more into neutral. And the next week, a little bit into extension. This is also called serial casting. Serial means over time, many instances over time. So static progressive splinting and serial casting are the same thing. Both of those have to be a hard surface. Otherwise, it will not provide the stretch. So with kids with CP or with spasticity of any kind from a brain injury or some neurological issue, you have to provide prolonged, see those keywords there? Prolonged stretch, maintaining the joint in a position. We're not doing quick range of motion. We're doing prolonged stretch with serial or over time changes in the position. This is just a different type of splint. This is a semi-dynamic. You know it's semi-dynamic because it is soft, and that does not look like it's going to completely prevent movement. It's going to facilitate. So for this kid, we're trying to facilitate extension with this 3-point style semi-dynamic splint. So fracture bracing is another thing that you might do if you are seeing children in an outpatient clinic. Sometimes doctors like this better than casts, but it is up to the doctor's suggestion or protocols. Here's some examples of, the fracture bracing in the middle, the bottom middle one, that basically serves the same purpose as a cast, but it can have a clamshell, like two different sides of the brace so that it can be taken off and on if necessary. But you would have much more specialized knowledge being a certified hand therapist. That's beyond entry-level practice to be making fracture braces. The top right-hand picture, the Bennick picture, that would not be appropriate for a newly fractured arm. That might be to months down the road to add extra protection if necessary. So how do you choose what splints to use when? You have to know, what do I need this for? Do I need it to immobilize? If I need it to immobilize a joint, then I need a static splint. I need a hard splint. If I need it to improve hygiene, that might be some, like, by hygiene, that means like a lot of people with spasticity keep their hands super tight and then it gets really skin breakdown and bacteria in there. So maybe you need a comfy splint that is still static but serves a different purpose. Let's see here. So there's tons of different types of material to make splints out of. You do not need to memorize them for this. You've seen some of the different types when you made, like, these three are just different brands. Like there's Aquaplast, Easy Form. The more expensive they are, obviously, the easier they are to work with. They don't fold over and grab each other quite as easily. Different materials that splints can be made out of. We already talked about neoprene and lycra, which are like the wetsuit material. Adapted pellets, those are kind of like splinting material made out of what's that ice cream? The Dippin' Dots. So there's a whole bunch of little plastic pellets that you warm them up, and then you can mold them into whatever position you want. So if you're using a splint for joint stability and you have a scar that you want to provide pressure to prevent scarring, keloid scarring, then consistent pressure on that, you might want the splint to have a little bump in it to keep that pressure, and that would be adapted pellets. So these are all choices of different levels of straps, different types of Velcro. So Saber Grip and Polylock, Duolock, those are all brands of Velcro that have different qualities. So like the Polylock is super, super strong, but it's hard and scratchy. The Saber Grip is soft and strong. These are you have to choose. So in your class, when you did the splints, you just had Velcro straps and hard static plastic sheets, right? But when you're really in OT, and if you're doing this specialized in it's the hands clinic, you're going to get to choose what is the most appropriate strapping and the most appropriate material to make the most appropriate splint for the reason. Again, just like the material and the straps, there's different types of padding. You should not need, if you make a good splint, most of the time you should not need padding. The padding can increase pressure. It can decrease the amount of available space around the splint. So try to stay away from padding unless absolutely necessary. Okay, so some other tips for pediatric splinting. So a hand clinic is where you might do this. Also a hospital. So if, like with a burn survivor for a child, if you were to have to go into their hospital room to splint their arm in that airplane cast or a neck cast, or splint, you have to make sure that you have safety first, because kids, imagine the way that you had to make your splints in lab. Imagine you were doing that on a 5-year-old who is in pain, with all tubes and stuff attached to them. So you have to have other adults with you, stay alert, make sure that somebody else is managing maybe the child and the lines, and you're working on the splint. Also, you know how the plastic sticks to other plastic? So all of those wires coming out of the kids are plastic. So you would put lotion on the wires, like the catheter or the oxygen tube or whatever, so that the splinting material does not stick to those wires. And of course, we don't want them to pick up small pieces and eat them, or get the scissors or the hot things. So extra careful with safety. You can make them look cool. Kids might want to wear them more when they look like this one's made with like a little dog. Just looks fun. Okay, so one of the main reasons why we would splint or use orthotics for a child is high muscle tone. And we're going to need to remember way back to neuro and the mechanisms in the brain for what causes spasticity. So what causes spasticity, it's the simple stretch reflex. The simple stretch reflex is a monosynaptic reflex, and the muscle spindle is a feedback mechanism that modulates the alpha motor neuron output. So when we're talking about spasticity, we're talking about the muscle spindle and the stretch reflex. So our goal by splinting for spasticity is to rebias, forget what I just said, REBIAS, rebias the muscle spindle by maintaining prolonged stretch that will reduce the stretch reflex, because the spasticity is a hyperactive stretch reflex. So the motor neuron and the skeletal muscle fibers, they can be rebiased or kind of retrained through sustained stretch. All right, so we know this is the definition of hypertonicity, otherwise known as spasticity. These are some hypothesized reasons for why we get spasticity. Go back and look at gamma hyperexcitability, which is the Y alpha motor fibers. Those help to modulate the skeletal muscle tone and the intrafusal muscle spindle. And then we've got alpha hyperexcitability, which is the alpha motor neurons. And those, so when there is an imbalance of the descending inhibitory stimulation, then that's when the muscles get too tight. So the hypertonicity is really the muscle's response to passive stretch. So out of all that, you should write down this sentence. Ready? You should write down velocity dependent increase in muscle tone caused by increased excitability of muscle stretch reflex. So we believe that hypertonicity is a velocity dependent increase in muscle tone caused by an increased excitability of the stretch reflex. So if you see somebody with spasticity or high muscle tone, that is a clinical manifestation of an upper motor neuron neurological disorder. Spasticity is not a muscle problem. It is a neurological problem. Spasticity or hypertonicity is a clinical manifestation of an upper motor neuron neurological disorder. So here's just some pictures of what we just described. We can use sustained stretch. This is the serial casting, or the inhibitory casting is used to decrease muscle tone or spasticity by giving sustained muscle stretch, and that the splint itself creates a neutral warmth. You can also use a outdoor temperature, or the like a pool or a heating pad. Those help to reduce spasticity. When we're talking about reciprocal inhibition, you should remember the agonist and antagonist muscles. The agonist muscles creating the contraction, the antagonist muscles creating the relaxation. So our goal is to rebias the muscle spindle to reduce the stretch reflex. And you can only do that with a static progressive splint, a hard splint that has maintained long stretch that proceeds over time. Just like with adults, you should worry about all these contraindications or issues for splinting. You should not use splints if they have compromised skin integrity, have circulation problems, if you're going to be getting in the way of IV access, if it's going to cause pain and they have increased blood pressure or a TBI. Hello. Sorry, I had to move. My family came home. All right. So I'm back. When it says family or patient noncompliance, go. That was perfect. Family noncompliance. I just told them I was recording. Okay. So I don't want you to give up easy when it says family or patient noncompliance. That means like you have tried everything. You've used your education, your ability to educate them on why this is necessary. You've went back multiple times. You have rapport with them, that you know they're understanding what's going on. So I would say a long-term family or patient noncompliance, you might not want to keep up with it, but you have to really try first. If you end up working with somebody who's had a contracture for their whole life, let's say you have an 18-year-old with CP that has been contracted in the same position for the last 13 years, you're probably not going to be able to fix that with a splint. And then, of course, acute heterotopic ossification, if they have that heterotopic ossification where any pressure point creates bone there, you definitely don't want to use a splint. Looking at some lower extremity splints, this is just showing spasticity in the lower extremity. This is an inhibitory cast or splint that can give pressure on the Achilles tendon and put the foot in dorsiflexion, can help to reduce spasticity in the whole leg. This is a full upper extremity cast that might be used for CIMT or constraint-induced movement therapy. That is a plaster material, so that is a static splint. It's not going anywhere. It's stuck in that position. So you might use this on their non-affected extremity. If they have CP, if they have hemiplegic CP, you might use a hard static splint like this or cast like this. I'm gonna start blocking the fucking fridge and freezer. I'm back again. All right. Let's finish this up. So I think I was saying that for CIMT or constraint-induced movement therapy for kids with hemiplegic CP, this cast would be on their unaffected extremity, so that their affected extremity, the other side, would be able to be forced to kind of do more work and get new skills by being used more. This is just more examples of a static, inhibitory, lower extremity cast. This would be a KFO or a knee foot orthotic. This is a KFO with a hyperextension toe plate to make with the toes in hyperextension that will also reduce spasticity. Just another example. Sometimes people are using air casts, not very often, but you might use air casts in an example like this to facilitate elbow extension during weight bearing and maybe crawling. If it's not something that you're going to need specialized to the child or long term. So this is an example of a weight bearing splint that can also be used with an Eric splint or not specialized splint to create elbow extension through weight bearing in a fun activity. So of course, all of the splints, whether they're dynamic, semi-dynamic, or static, should be used in conjunction with functional occupation-based activities. You're not just going to be a person or a dispensary of splints or orthotics. Make sure that you're using them to meet a specific need for the child and using it in conjunction with functional activities. So there is orthotics. I hope you're having a great day, great life. Let me know if you need anything. Just reach out to me individually by email, text, Teams, and I will see you soon. Have a great day, guys.